Good morning. This is Dr. Rich Shoemaker. Today's talk is Lessons from GENIE. This is the second in a series of discussions of how GENIE can assist primary care physicians looking at complex medical illnesses. Today's talk is on what do the data show. GENIE is a blood test. Gene expression inflammation explained is what the acronym means. It's a research use only assay of messenger RNA found in white blood cells. Patients who enroll are de-identified. We know them as a number. There's an age, gender, and race given, but no other personal health identifiers are known. Physicians must order the test. It's not a direct-to-consumer test as yet. Interpretation of the results may take some familiarity with the jargon regarding gene names and the role of differential gene activation. It's a steep hill, but one that is climbed every single day. The process of GENIE brings to the future today's personalized comprehensive care. Next slide. A few housekeeping issues before you start drawing blood. We use PaxGene tubes. The protocol is exacting. It is available to you at www.survivingmold.com, which is where you can order GENIE if you choose. The directions for draw and processing are straightforward, but they really do need to be followed. The test itself is not fasting. Our draw times are 9 to 11 a.m. to avoid gene activation seen in afternoon compared to morning. Following the last sample of a phlebotomy draw, the GENIE tubes are inverted 10 times to mix the diluent, the preservative that maintains stability of messenger RNA. The tubes develop at room temperature for 240 minutes. That's not 235, it's not 245, it really is timed. Once the blood has been stabilized, it's ready to freeze until it's shipped to the lab on dry ice. We all make mistakes, and mistakes, unfortunately for GENIE, mean a redraw. If the blood arrives, the lab thawed, there wasn't enough dry ice, there was a problem, it has to be redrawn. If total mRNA drawn is inadequate, and we count the number of mRNA molecules in the millions of reads, both GENIE tubes must be full before they're sent. If the tube is clotted, it's been not inverted 10 times and can't be used. If the information sheets have not been completed, we will contact you and ask for the information on the telephone. We really do need that information. If, for example, a wrong patient ID code is written on a number, clearly that's a mistake. That means a redraw coming up. Next slide. GENIE itself is a transcriptomic assay. The forerunner was a device from Illumina that gave us RNA-seq. GENIE is less technically demanding since it's less reads. It's also less costly since it's less reads. There are no shortcuts, however, in quality control. And speaking of controls, we never have enough. So if you feel like sharing control samples, contact us and we'll be glad to talk to you. The case versus control study design generates a z-score in the report such that you will see the number of standard deviations of cases compared to controls if there are any differences. Specimens must be extracted right and processed right as discussed. Interestingly, we're only after 3% of the total RNA, that's the mRNA. Next slide. GENIE is expensive, it costs $725. Who needs it? Well, as we go further into this process of using GENIE in clinical medicine, just about everybody with inflammatory illness will benefit from knowing what GENIE has to bear. Everyone with disproportionate gray matter nuclear atrophy, when we stratify NeuroQuant by age, of course, needs GENIE. Everyone with failure to improve for CIRS protocols, as expected, needs GENIE. Everyone looking for more information about their illness, whether it's CIRS or not, can benefit from GENIE. Everyone demanding state-of-the-art medical care and step-by-step assessment of GENIE provides for the most efficient approach to cure. Next slide. Some examples of who needs GENIE. The question of Lyme, when it comes up, we will rely on the work from Drs. Bouquet, Alcott, and Chu, published in 2016, looking at the transcriptomics of untreated Lyme disease and treated Lyme disease. Many people are concerned about mycotoxins these days. That may be an untoward emphasis, because less than 10% of CIRS patients will show typical gene response, even though they've been exposed to water-damaged building. Marcons creates all kinds of headaches, as its antibiotic resistance patterns have been changing rapidly in the last 5 years. Injury from Marcons, which we feel comes from polycyclic ether production, is shown by GENIE. When we ask about what mitoribosomes tell us, well, there's the first step of some jargon. These are ribosomes found in mitochondria. Specifically, however, the most common actors making people ill from water-damaged buildings are actinomycetes and endotoxins. If GENIE says that you have exposure, then you need to do the testing. Next slide. Some examples that might not be quite so obvious. Do I have necroptosis is one of my problems. About 1/3, fascinating, 1/3 of chronically ill patients with CIRS will have defective apoptosis. This creates an endogenous source of inflammation. When packaging of intracellular organelles and ribosomes and DNA is not done properly, there will be intense inflammation. Many people want to know, do they have cytokine activation? It's very hard to get a direct measurement of cytokines because the actual production or endocrine effect can be skewed because we can't measure autocrine or paracrine effect for cytokines. These days I hear a lot about mast cell activation syndrome. If we show upregulation of histamine genes, that means every nucleated cell in your body could be producing extra histamine, not just mast cells alone. PTSD finally has some objective parameters to assess potential injury. GENIE will tell us more about PTSD. And the fascinating vascular hypothesis of neuronal injury shows great promise for diagnosis and treatment of conditions before dementia sets in. Next slide. For those getting ready to use VIP, what dose do we use? For example, if VIPR1 is suppressed, we need to be cautious and start at a lower dose and increase it more slowly. If Icarus is already upregulated, then we can go a little quicker. So many people are interested in methylation. Clearly, they need to know about demethylation as well. GENIE can help with that. Of tremendous importance in looking at the cure word is defining whether or not the T-cell synapse with dendritic cells is actually working. CD38 and CD3D and CD48 help us along these measures. Many people will have platelet-related clotting problems as manifested by tubulin activation. It's not as common as some other findings on GENIE, but it needs to be paid attention to when you find it. Similarly, on the other side of clotting, with too little clotting, there can be evidences of risk of hemorrhage, particularly nasal hemorrhage, if a patient exposed to a water-damaged building. We will rule out, of course, acquired von Willebrand syndrome illness. Next slide. At the bottom of the list of concerns, at the bottom of Pandora's box, there lies the butterfly of hope. That is cure. Is cure available? GENIE brings concrete hope using tested, validated, and measurable parameters to primary care. GENIE lets one have a front row seat to the very basis of inflammation. We now understand that DNA action and activation is a dynamic source of regulation over all cellular responses. Failed treatments unrelated to DNA will go away as modern medicine turns inwards towards DNA as a source of what we need to be aware of. Next slide. Today I'm going to share with you patients stratified by stage of treatment. Stage 1 is naive. This is a baseline before treatment begins. There's 49 patients from today's data set. Stage 2 is after the first 11 steps of the survival protocol, also called the Shoemaker protocol. There are 46 patients in this cohort. Stage 3 is after VIP. We only have 11 patients. And stage 4 is off all meds. We only have 10. The statistical certainty of these smaller data sets is subject to some discussion. We will not be presenting the non-cases for whom we have GENIE data, but there are 45 altogether. Next slide. So we have 161 patients all told for today. 50% are men, 50% are women. Mean age, men 46.9, mean age females 47.6. There are no racial differences that we can tell, but the numbers might be too small as we sit here today. Next slide. The most important concept of GENIE is molecular hypometabolism. That is downregulation of ribosomal RNA gene activity, as well as reduction of nuclear encoded mitochondrial genes. Over the 3 billion years, there have been 1,000 genes migrated from the mitochondria to the nucleus, and there in the nucleus they are subject to nuclear transcription factors as well as the other layers of regulation of DNA activity. If we look at stage 1, we find that 79% of patients will either have strongly positive reduction of ribosomal RNA or mitochondrial, nuclear encoded mitochondrial RNA. We'll find at stage 2, we see tremendous improvement. We're down to 28% abnormalities with stage 3 and 4, less and less. Fundamentally important correction of mitochondrial and ribosomal gene activity means removal of ribotoxins and ribosomal inactivating or inhibitory proteins. Next slide. I mentioned mycotoxins were possibly overrated. For stage 1, we find 7.1% of our patients. In stage 2, 7.6% are showing typical gene activation associated and published in the literature. Next slide. Actinomycetes, 36% at stage 1, 47% at stage 2. Still is a problem with stage 3 and stage 4. It takes a while to obtain cure. Actinomycetes are rarely understood, rarely discussed, but fundamentally important. Next slide. Gram-negative rods will create endotoxins, and endotoxin response to exposure is 26% of our cohort. In stage 2, it's down to 13%. We look at RIP, next slide. We look at RIPK1 to look for evidence of defective apoptosis. Very common in stage 1, 32% of all patients, but with the Shoemaker protocol, fortunately we're down to 4% in stage 2 and none in stage 3 and stage 4. This concept of defective apoptosis bears repeating. It is by far the most common reason for failure to respond following ongoing exposure to water-damaged buildings. Next slide. Coagulation genes, we have 9 in GENIE, are upregulated excessively in association with increased gray matter nuclear atrophy. Stage 1, we see 26%, and stage 2, 30%, but much less for stage 3 and stage 4. We find that VIP has been the very best compound to correct coagulation gene upregulation. Next slide. If we look at the mean coags by stage, we see that stage 1 and stage 2 have about 20% upregulation, 21% are stage 3 and 4. I'm not sure our data for these stages are as reliable. This is an ongoing, exciting field of interest. Next slide. The most common coagulation genes upregulated by stage, for stage 1, factor 5, integrins, and thrombospondin. Stage 2, factor 13, factor 5, glycoprotein 6, integrins, SCLP, and thrombospondin, and then just factor 5 and glycoprotein 6. The stunning finding for this slide is that how many of these genes have products that are hurting us that we actually can measure with proteomics. We need GENIE. Next slide. The vascular hypothesis of neuronal injury And I would commend people to read the excellent literature from Sidney Strickland's lab in Rochester University in New York. Basically, beta amyloid binds to coagulation products, creating a microclot in capillary circulation in the central nervous system. Distal hypoxia will form, as this clot is pretty much resistant to lysis. Tau formation in distal hypoxic areas is increased and phosphorylation occurs. This is the sequence of events felt to be responsible for ongoing neuronal injury. As an aside, microbleeds are common with people with microclots, such that we shouldn't be using just the words TIA anymore if the MRI doesn't show a microbleed. Interestingly, VIP will correct atrophic nuclei, excess, and coagulation gene products. Next slide. Speaking of atrophic nuclei, we find by stage 1, 4.2 out of 6, stage 2, 3.8 out of 6, 3.3 and 3.0. We need to look for age-related changes to understand improvement in NeuroQuant. Next slide. If coagulation genes are recorded, then we can look at atrophic nuclei added to forebrain parenchyma and cortical gray. The possible score is 8, and this is an older slide. Suffice to say, if you have 3 or more coagulation genes out of whack, you will find increasing percentage of areas of injury in the central nervous system. Next slide. CIRS biomarkers by stage. We look at eukaryotic initiation factor. We look for NEAT1, nuclear enriched adenine transcript, one of the ribonuclear proteins and long non-coding RNAs that regulate gene transcription. NCOR is another regulatory element for gene transcription. Tremo, and then VIPR1. Fascinating. Next slide. If we look at the role of beta tubulin 1 with coagulation, just comparing stage 1 to stage 3, we don't find a lot of beta tubulin 1 in those with coagulation 3, with 7 out of 49, but we don't find any with less coagulation gene upregulated, 0 of 46. Next slide. I mentioned CD3D. We know that positive CD3Ds is a good thing if we want good antigen recognition. Stage 1, 14 out of 49. Stage 2, 17 out of 46. And then we look at the smaller data sets for 3 and 4. We are looking at the cure word when we correct CD3D together with the rest of the parameters that GENIE measures. CD48, similarly, positive is uncommon in stage 1, more common in stage 2. Next slide. If we look at apoptosis genes by stage, we will see that LDL receptor protein and clusterin, together with Cas3 and 8 and Cas10, are increased in stage 1 compared to stage 3. Stage 2 shows that we need more than just the protocol. We also need VIP. But correction of excessive apoptosis is important, just as it's important to correct defective apoptosis. Next slide. I mentioned histamine genes, CCL5 and histidine decarboxylase are ones we measured. Pretty common to find abnormalities in histamine, not related to mast cells. Next slide. A few genes to pay attention to. The PTSD or FKBP5 is quite commonly increased in stage 1, decreases in stage 2. Transient receptor potential vanilloid series have unusual peripheral sensory neuropathies. Prostaglandin synthase and its buddy ALX15 are increased in stage 1 with less in stage 2. Next slide. We can look at GENIE to look for possible associations. For example, a concept was that Actinomycetes exposure was more likely to be associated with defective apoptosis. We found that plenty of actinos upregulated but didn't find correlation as tight as we thought with RIPK1. Stay tuned. We are still looking at this phenomenon. So using GENIE for data mining can lead to cave-ins. RIPK1 is just one example with the association of actinos. We're not quite sure that was right. Many things aren't always obvious. The beta-tubulin 1 role and the beta-tubulin A4A are hugely important in coagulation. Of course, we need more controls. We always will need more controls. The stage analysis supports continued use of this treatment approach in developing a before and after cohort with the patient as their own control is our current emphasis, with data confirming what the case control series showed. Next slide. The new information that GENIE can provide of clinical value comes from novel therapies. The Shoemaker protocol has been out for nearly 20 years. There are newer therapies that are coming along. Is it time to push aside the old standby for something better? Let's see the data. Let's not guess. Let's not rely on anecdote. Focus on remediation on minutia for water damaged buildings isn't necessarily helping cures. We thought it might, but it doesn't quite appear that way. For example, HERTZ-Me2 is an absolutely outstanding measurement to show safety of reoccupancy of water damaged buildings by CIRS patients, but it can't possibly show endotoxins or actinomycetes in their role in illness. And similarly, there's nothing about a building assessment that will give confirmation correction of T-cell synapse as a target of therapy, except for GENIE. Having said all that, actinos dominate GENIE, and I have to ask the question, why are we still obsessing over mycotoxins? Years and years of emphasis on mycotoxin was based on years and years of ignorance of other factors that are more important. Let's get with the program. Better yet, what treatment of a house will correct GENIE enough for reoccupancy for a CIRS patient? When we identify those parameters, and removal of actinos and endotoxins lead the list, then we will need to change our approach to building therapy to speed up recovery. It is a new day in diagnostics. It is a new dawn of therapy. Imagine if patients could know what they don't have. Look at what money and misery they would save. Lyme disease is one example. Cost savings for avoiding prolonged antibiotics for those potential hazards are real benefits to GENIE. But more importantly, imagine if mycotoxin injury were ruled out. We were then looking at testing that is currently being done that's, I think, exaggerated in its influence. Similarly with mast cell activation. It's just that not big a deal when you fix histamine production by correcting GENIE. The idea here is that we can not only become more efficient with therapy, but more cost-effective as well. I've tried to talk a bit about GENIE, and the thoughts for the future are already being formed for 2020 and beyond. The insulin receptor recycling that we see that is problematic when there is presence of molecular hypometabolism is real. Neuronal injury reversal we're already working on. The difficulty is how do we get brain tissue to be more reliable than just white blood cells. Having said all that, the basics of history, physical differential diagnosis still are mandatory. Bedside medicine begins with observation and physician-trained skills. We use visual contrast sensitivity, we use NeuroQuant. We have about 20 different biomarkers that we use that have been published and peer-reviewed. But now we ask, does differential gene activation need to be corrected? If the answer is yes, help is on the way. Thank you for your attention.